gigantic effusions, and tension, pneumothorax, right? Someone said cardiogenic. What else? Sort of with the bleeding, what is aorta too? Anything else? No, I think it's right. Okay. So did everyone grab the RUHS exam thing? No? So if you've got a shocked patient, right, and no one knows what's going on, then you can do this, and this will pretty much rule out or rule in most of these things pretty rapidly. Okay. So what you do is there's an acronym. Is that on there? HIMAPS? No?
That's not on it. It's in the article though.
Okay, HIMAPS. Okay. So the first thing is you look at the heart. Okay. The next is the IBC. Then Morrison's pouch, the aorta, and for the lungs for pneumothorax, pulmonary. Okay. So the views are going to be the parasternal long, and you can just rotate to parasternal short, subxiphoid, right upper quadrant with the ultrasound probe like this. Okay. And then subcostal and IVC. Okay. You don't have to do you can throw out the parasternal and the long and short if you're satisfied with your subcostal or subxiphoid. Okay. So you can get the heart and the IVC out in one if you wanted. Aorta. Okay. And then just like with B lines, except for you are looking for B lines here, but you're also looking for a pneumothorax. Okay. So the heart is going to be the kind of the most complicated of all this, and you're going to kind of look at it with what's going on with the IVC too, of course, right? So you guys kind of already, I think, know enough about what you're looking for with the heart, but so first of all, how is the left heart beating, right? So if it's doing this, right, then there's a good chance you're doing this, right? Especially if you've got V lines all over here, right? If it's doing this, right, you could be here, you could be here, you could be here. You're going to see the RV looking funny here, but so we'll get to that. But you can tell if the heart is thinking that it's that isn't getting filled or it is getting filled, and it's not dealing with that filling well, right? So there's that, and then you want to look at the left ventricle and the right ventricle, right? So that septum shifting over. What's the size of the right ventricle? Because normally that right ventricle should be kind of like pretty small compared to the left, less than 2/3 the size of it. And a lot of times it's even smaller than that, right? So that's where you might get a little help with the parasternal short as opposed to just the subcostal. But you want to look at the RV and the LV interaction, and then pay attention to that RV, because if it looks big to you and you see an IVC, right, there's a couple things. The fluids is the wrong choice probably here. And also that you could be dealing with a PE, okay, or decompensated pulmonary hypertension too, okay. If there is fluid around the heart, right, then we're thinking that tamponade could be going on here too. the get-go say, oh, this is cardiogenic shock because it's that big, huge left ventricle. Or a tamponade, we'd see if it's just crushing the right ventricle with the fluid in there, right? Okay, so then we move on to the IVC. So the IVC is going to be big, small, or normal, right? So if it's normal, it doesn't help you out. If it's super big, then you're thinking that we could be dealing with the PE, a tamponade, tension, pneumo, or fusions, or a cardiogenic shock, right? If it's small, then we're dealing with hypovolemia, bleeding, sepsis. This neurogenic thing, this is going to be your C-spine, spinal trauma patients. Everyone's not going to get fooled with that, right? So the small IVC should clue you into those ones. Is that like really clear? Everyone's kind of just intuitively knows that, right? That's how that's going to work. Okay, so one thing you guys probably haven't seen is the Morrison's pouch, right? No? Okay, so what it looks like is this. Here's your ultrasound beam, and you're going to put, like I said, the ultrasound like this. Okay, kind of where the ribs sort of are meeting up with the abdomen, Maybe if you go, a good place to start is like about the subxiphoid and move across like this, and then maybe up and down a little this way. Okay, and so what you'll get is a picture like this. Okay, and so this is the liver, this is the kidney, and this is where the lung is, this is the diaphragm, and this is the spine. Okay, so you can slide and get more view towards the diaphragm if you're looking for an effusion, or you can slide this way if you want to focus in down here and make sure that there's no fluid there. But if you have fluid in the abdomen, okay, what happens is the fluid will collect in this area, and you'll get like a black, very black area between the liver and the kidney. Okay? So either the patient has ascites, or maybe they have a perf duodenal ulcer, or it was on maybe Saturday or something like that, or I can't remember, but some guy had a hemorrhagic ascites because he started bleeding through like a AVM or something in his liver. Okay, and everyone couldn't figure out what the shock was, and to put the ultrasound on, I said, hey, there's clots all over his abdomen. Okay, so then they scanned him, and he had hemorrhagic ascites, and he went to IR, right? So black stuff in here, okay, on that, because this is where it will collect. It'll either collect here first or in the pelvis, okay? But does they have the pelvis on there? They do, don't they?
It says bladder view.
Yeah, okay, so the bladder view is like this. You can put this in if you want. It's from the transverse way, it looks like that, and if you go sagittal, like this, it looks like that. And the blood will collect here, and the blood will collect here. Okay? So that's the Morrison's pouch, and you can throw on the pelvis if you wanted to at the end, but I think if there's enough blood to make them shocky, it should show up there, especially if they're laying supine. Okay? Incidentally, this is going to be probably valuable in one subset of patients, and that's your Heather's with her ectopic pregnancy.
I cannot believe you put a bad juju in
Right?
there.
No, I saw the picture.
I passed that.
Yeah. So anyway, but an ectopic pregnancy, like you got a 30-year-old lady who's got pelvic pain, or maybe she doesn't even know, but abdominal pain, she's shocky. You see fluid in there, then ectopic goes like to the top of your list, right? That's why she's shocky. Okay. Okay. But what I would say though is if you see that, you still want to do this whole thing, because what if she is a pregnancy-induced cardiomyopathy, or she got a viral cardiomyopathy and she's got this big LV that's failing, right? So So yeah, so you ideally don't just kind of come to a conclusion before you're done looking at everything. Okay, so that's the Morrison's pouch, and then you go to the aorta, and this is going to be probably the hard one. And if you don't get it right away, I would just say just move on. If there's a big aneurysm in there, it's usually pretty easy to see. It's the normal aortas that are hard to see, okay, and take some patience, because what happens is that the valve, it's kind of filled with like liquefied poop that's not on its way to like real poop yet, right? And there's air and stuff in there, and the sound waves don't, when they hit the air, they just like scatter everywhere. So you have to get the bowel out of the way between your probe and the aorta. So you just have to sit there and push and wait for the bowel to kind of like peristalse out of the way, and then once it gets out of the way, you see the aorta. So the times that's going to be sort of important is when you have someone who didn't have like a previous aortic aneurysm, but they do have a dissection. Okay, but if you put the probe on there and you see this big fat aorta, you should be thinking, hey, this thing probably ruptured and it's leaking. If it, depending on how it ruptures, you may or may not get fluid in there. Usually you get retroperitoneal rupture, so you don't see the free fluid in there, but the retroperitoneum gets this look to it that looks different than normal. But what you look at for is you'll have the spine, right, with the shadow behind it. So think IVC in short axis, right? So remember how we talked about how if you can't find it, you just go short axis and look, right? So the aorta, if your thing's this way, is going to be sitting just on this side of the spine, and you'll have like your IVC like sitting right there next to it, right? And so if you see this big fat thing, you'll usually see it with like a thrombus in it too, around it, okay? But if not, you could have, just say it's like a Stanford A that's dissecting down from the aortic arch down the thoracic and to the abdominal aorta. You might just see like a flap in there, like that. Okay, so you'll see this in a normal size aorta. Aorta should be less than 3 centimeters. Okay, is the size there. But you can have a normal sized aorta with still a dissection. Okay, so that's the aortic part of the exam. Again, if you have a big aortic aneurysm that's ruptured and leaking backwards, you're not going to miss it. It's going to be really easy to see because the aorta is already up against the abdominal wall. But if it's just a dissection coming down from up in the chest, then you might have like a smaller aorta that's normal size. And remember on our peristernal long axis, we actually can see the aorta sitting behind the heart too. So you might, if you're thinking about it, see a flap there, right? Okay. I wouldn't bother doing the suprasternal. It's kind of, if you're really good, do it. But if you're not, don't waste your time because you could move on to this exam and it'd be higher yield. Okay. And then the last one is the pneumothorax. So you guys are already doing the B lines. Okay. But so you all know what B lines are, but what you're going to see here is the rib shadows, and then normally what happens is you'll get this sliding that happens between the parietal and the visceral pleura, right? You guys all know what I'm talking about. So if you don't see any sliding, then that's because they're not moving, and the most common reason that's happening is because they're not actually touching. There's air in between. So what you would see is your A lines, just like a normal lung exam, except for no sliding with the A lines. okay? Because you still get this back and forth reverberation artifact with just an air interface here. But the difference is that the pleura is not sliding, so you're not seeing that pleura around the lung, just the pleura on the chest wall. Okay, so A lines with no sliding is a pneumothorax. If you have a pneumothorax that's big enough to cause them to go into shock, then you'll see it if you just scan these, just like a quick 1, 2, 1, 2, just anterior mid-axillary line. You'll see it. Okay, a pneumothorax is like a real tiny 5% pneumothorax is not causing them to be hypotensive, right? These are large pneumothoraces that are causing it, right? So, but if you do see, the B lines, right, like this, and a big fat left ventricle, then that's your left ventricular cardiogenic shock, right? So that's something else you'll be looking for, right? So B lines or the pneumothorax. You don't need to go hunting this way or anything. Just if you see it, they're shocky, then go ahead and either stick a needle in. Probably it's better just to stick a knife in and stick your finger through. Okay. All right. So.
But pleural effusion, you'll see like dark.
So a pleural effusion depends on how big it is. Sometimes you'll see the fluid collection in here, and then you'll see the lung kind of floating, and the lung will be collapsed, so you'll actually see the lung. If the pleural effusion is smaller, that it's not coming all the way around and getting into the anterior chest, then what you'll see here, in this view here, and you actually can see it over here too, okay, where the spleen sits up against the stomach and the diaphragm here, so you'll have the diaphragm, the liver, or the spleen, and then remember I said that this is the spine down here. So take that probe and just slide it up this way a little bit to get up to past the diaphragm, and what you'll see is if there's no no effusion or no pneumonia, what you'll see is this here, and the spine just stops. And when they breathe and the diaphragm moves back and forth, the spine goes away and comes back. Like it never will cross this point. Okay? And the reason why is because when the sound beam comes down and hits the diaphragm, normally what happens if there was something on the other side of this besides air, is some of the sound waves would come and bounce this way, but most of them would transmit through, bounce off, things all the way along, come back up, and hit the thing. But because there's air in the lung, what happens is all of these sound waves just scatter and they're lost. And what happens is that as this comes here, it bounces off something, bounces back up in here, and the ultrasound machine doesn't know. It just is thinking that everything's going along the scan line. So what it does is it will put a mirror image about 90 degrees off here from where it is. Let's say you hit a portal, you see a portal vein or a hepatic vein or something here, it'll show up over here. And it's just an artifact of this like little bounce and reflection because it thinks that it went like this. Okay? Now, if you have a big effusion, suddenly we don't have air here anymore. We got fluid. So you'll see maybe a black stripe here, but this spine will come out underneath that diaphragm. Okay, so if there's a consolidation or like a socked-in pneumonia or atelectasis, or there's a fusion squishing things or whatever, you actually will see the lung in here, and it'll kind of look like this. Spine comes across, and you may have fluid here and like a little jellyfish thing like floating around in there, and that's like an atelectatic lung. It's not filled with air. Okay? But so every now and then you won't see the fluid, but when you see that spine go past that diaphragm, then that's actually lung you're transmitting through, and that's not air filled, lung filled with air. Okay? So so that's the RUHS protocol. Okay, so plus or minus parasternals, subcostals for sure, IVC, lungs, Morrison's pouch, aorta. Okay, and then also you could add in the suprapubic piece too. Okay, and you can do the left upper quadrant like on the Morrison's too. So what I would do is I would probably do this: parasternal long, parasternal short, subcostal, IVC, Morrison's, spleen view. Come to the bladder, look at the bladder, look at the lungs, and then if you haven't figured anything out, then spend a little time on the aorta. But if you just do high max, that's the acronym. Okay. All right. So most of your meat is going to be here, right? In that, that's where you're going to see your tension pneumothorax, your tamponades, your cardiogenic shocks, your distributive shocks.